Hello students, welcome to Injections Lecture 3 on intramuscular injections. So IM injections are given deep into the central area of a muscle. This is away from large nerves and blood vessels. IM medications are absorbed more rapidly than through sub-Q route. Recall that muscular tissue is much more vascular and has a lot more blood flow than adipose fatty tissue. Muscle tissue can also typically hold a larger volume of fluid without causing discomfort, such as sub-Q would. And large muscle sites are used for irritating medications. So the route is into the muscle tissue. Syringe types are 2 through 5 milliliters hypodermic syringe. The dosage range is going to be 0.5 through 5 milliliters. But doses over 3 milliliters should be divided and injected separately. The needle gauge should be 22 through 25 gauge needle. Most commonly is 25. Needle length should be 5/8 of an inch to 1.5 inches long. And 1 inch is the most commonly used length. For large patients, you may need a 2 to 3 inch needle depending on the site. The needle should be long enough to reach the muscle mass. And remember, it has to get through the dermal layer of the skin and the subcutaneous layer into the muscle underneath. This is to prevent the vaccine or whatever's being injected from seeping back into the subcutaneous tissue. You don't want the needle so long that it goes through the muscle and involves any underlying nerves, blood vessels, or even bone. This can happen. The decision on your needle size and length needs to be made for each individual patient based on the size of the muscle that you're injecting into and the thickness of the adipose or fatty tissue at the injection site, as well as the volume of the material that you're administering. Intramuscular injections will always be at a 90-degree angle. That's so that they can get through the skin, the fatty tissue, into the muscle. Aspiration. Okay, so this is a technique that we use that involves pulling back on the plunger of the syringe after the needle has been inserted, but before injecting, to ensure that the needle is not in a blood vessel. So when you pull back on the syringe ever so slightly, if the needle is in a blood vessel, you will see a flash of blood down at the hub of the syringe. If you see this, you're going to withdraw the medication and dispose of it, and you have to start over with a fresh one in a new site. Now, the CDC does not require aspiration for vaccines and immunizations, either IM or sub-Q, as well as with insulin or heparin. And that's because where we give insulin and heparin in the abdomen, there are no large blood vessels there. And they have decided that vaccines and immunizations are still okay if they do enter into a blood vessel. But any other medications that you are administering, you want to aspirate and cancel the administration of that medication if you find blood in the syringe. Okay. So any medication other than a vaccine or immunization you should aspirate on. And you should be practicing this in the lab when you're giving injections into the muscle. Common IM injections are vaccines, antibiotics, hormones, fertility drugs, vitamin B12, epinephrine, antiemetics, analgesics, anti-inflammatory drugs, cortisone, contraceptives. Most commonly, antibiotics are rocephin and bicillin. Most common hormones are testosterone, estrogen, and other fertility drugs that stimulate ovulation. Antiemetics that are commonly given are Zofran, Phenergan, and Reglan, as well as epinephrine in the setting of an anaphylactic shock. We give lots of vaccines via IM. COVID-19, DTaP, Tdap, DT, TD, Hib, all of these combo ones, Hep A, Hep B, etc. Influenza, lots and lots of them. You can see the long list. We're going to talk about our 3 intramuscular injection sites. You should also have a chart such as this one handy that separates out the recommended needle length and volume based on your patient's age, as well as the site that you're injecting into. So you can see that the deltoid is not recommended for infants, and then for toddlers, these are the sizes that you should be using, as well as the maximum volume amounts that can be administered per site based on the patient's age. So for vaccines, we only use 2 of these sites. Deltoid is the most commonly used, and if that's contraindicated, we can use the vastus lateralis. And this depends as well on the age of the individual and their degree of muscle development. There's no major nerves or vessels near these sites when it's administered properly, so they're fairly safe. So for a newborn, the vastus lateralis is the recommended vaccine site. For an infant as well, vastus lateralis. For a toddler, we still typically use vastus lateralis, but if the deltoid muscle is large enough, if you have a large, well-developed toddler, that can be used. For older children, we tend to prefer the deltoid, but we could use the vastus lateralis if needed. And for adults, deltoid is preferred, recommended, but the vastus lateralis could be used. For deltoid injections, typically you're going to use a 22 or 25 gauge needle into the deltoid muscle of the arm. And then here's a nice chart depending on how large and the gender of your patient, kind of a standard needle length. So for small patients, we're going to use a 5/8 of an inch needle. Okay, as long as you're not bunching up the subcutaneous tissue on the outside of the arm and it's given at a 90-degree angle. For very large patients, we will need a 1.5 inch length needle to get down through the subcutaneous into the muscle. Now, if you have a patient with a very small arm, fairly small deltoid muscle, if you put in a 1 inch needle, especially a 1.5 inch, you could hit their bone. Okay, and that is a rather disconcerting thing to have happen. So always look at your patient, assess the site, and choose your needle size accordingly. We're going to be administering in the central and thickest portion of the deltoid muscle. You want to make sure your patient is in a sitting position. It's going to be difficult if they're laying supine. You want to make sure their shoulder and arm is fully exposed. And this is super, super important. Make sure their arm is loose at their side and the muscle is relaxed. If they are tense and they have their deltoid muscle contracted, it's going to be impossible to get that needle in there in a smooth and comfortable manner. You always want to locate the acromion process, which is the bone at the top, at the shoulder, where the collarbone connects. And then you want to locate the axillary line. So you just look at the front and the back, where the crease is at the beginning of the armpit. And you're going to measure about 2 to 3 fingers below the acromion process. That should be your injection site, right in the center of the arm. and it should be above the axillary line or the level of the armpit. You don't want to ever inject below there. Make sure you're using a needle long enough to reach the muscle. Insert the needle at a 90-degree angle with a quick darting motion. Administer the medication slowly and steadily. Use the patient's non-dominant arm if possible. Use a maximum volume of 1 ml in the deltoid. Vastus lateralis. This is on the anterior and lateral aspect of the thigh, which is why it's often called the anterolateral thigh. It's generally thick and well developed in patients of all ages, even babies, and it's not located close to any major vessels or nerves. It's also easily accessible to both the provider and the patient who might be administering IM injections at home to themselves. Put the patient in a supine or sitting position. Locate the greater trochanter and the lateral femoral condyle. Measure a hand's width above the knee and a hand's width below the greater trochanter. And so you're pretty much right in the middle third of the thigh in the central and thickest part. That's going to be your injection site. Make sure you use a needle long enough to reach the muscle. Insert at a 90-degree angle with a quick darting motion. Administer the medication slowly and steadily. Use a maximum volume of 2 mL in the vastus lateralis. So here, this MA has their left hand on the greater trochanter, and they've located the condyle there, and they're measuring a hand's width, and they measured a hand's width from both sides, and so they're pretty much right in the middle. Okay, and this is their injection site. Nice big muscle there that you can hold and visualize. The ventrogluteal is the preferred location for large volume and deep muscle IM injections. And you can put up to 5 mLs in one injection, depending on the age and size of the patient. The medications are absorbed quickly into the bloodstream, so this is a good way to deliver treatment in a fast manner. And it's pretty safe, reliable, and accessible. And it also has good bony landmarks to help you locate the correct injection site. And there's very little danger of hitting any blood vessels or nerves. Okay, so these are our landmarks: the greater trochanter, the anterior superior iliac spine, and the iliac crest. So step 1, you're going to have your patient lie on their side on the exam table. So if you're injecting into their right side, you're going to use your left hand to landmark. And if you're injecting into the patient's left side, you're going to use your right hand to landmark. So right here, this MA is using their left hand to landmark the patient's right side. You're going to locate the greater trochanter, which is the outside of the top of the femur where it enters into the hip, into the pelvis. You're going to locate that, and you're going to put your palm right on there. It's going to feel firm and round like a golf ball. Okay, so palms right over the greater trochanter. You're going to make sure your thumb is pointing towards the patient's groin. Okay. And then you're going to locate the anterior superior iliac spine with your index or pointer finger. Okay, you should be able to feel it unless your patient's very obese. And so I like to call this the as is. A for anterior, S for superior, I for iliac, and S for spine. So remember as is with your point to the as is. Then you're going to spread your remaining fingers away from your index finger and point towards the iliac crest. And your injection site is going to be right in the center of the V that you have formed with your fingers. Okay, right in between where the knuckles are. That's your injection site. Okay. This MA went ahead and injected right into the dummy for photographic purposes, but you want to be really careful doing that if you still have your hand there. You want to make sure you don't accidentally hit your hand. So as long as your site allows it per policy, you can often use a fresh alcohol antiseptic wipe and place it on the patient with the corner pointing right towards your injection site after you've landmarked it, and then you can remove your hand. And this, I think, is a much safer way to insert the needle into the patient and make sure you're still going into the correct injection site. You're going to always go to 90-degree angle. You're going to aspirate if it's a medication, and you're going to inject the medication slowly and steadily. Okay. For demonstration purposes, gloves were not worn in these photographs, but you're always going to make sure you wear gloves when you're administering any injection. The dorsal gluteal site is no longer recommended. In fact, at PAMF, I don't think you're even allowed to use that. And the reason is because it's very close to the sciatic nerve, so there's a high possibility of accidental injury to the nerve, which can cause the patient a lifetime of pain. So caution must be exercised if you're ordered to use this site. Okay, and you have to carefully identify your landmarks. So this is our last resort if no other muscle site can be used. You never want to use in children under 3 years of age unless they've already been walking for a year, so they have well-developed gluteal muscles. And then, as always, large and obese patients will require a longer needle to make sure that it gets to the muscle. So you're going to basically divide the gluteus into 4 quadrants by drawing 2 imaginary lines. Okay, so you're going to draw a line splitting it in half vertically, and then a line splitting it in half horizontally. And your injection site is going to be in the upper outer quadrant. See here, we have an X here or an X here. And of course, you're going to insert at a 90-degree angle. You also want to be able to locate the posterior superior iliac spine, as well as the greater trochanter. And you're going to draw an imaginary line between the 2 of them, kind of a diagonal line. And then that helps you also find your upper outer quadrant. So you want to make sure you never cross that line because you're going to have your sciatic nerve there. As always, inject at a 90-degree angle. The Z-track method. So this is a method used in IM injections that seals the medication deeply within the skin. And this allows no exit path back out into the subcutaneous tissue or the skin. So what you do is you use your non-dominant hand to pull and stretch and move the patient's skin and tissue. And so you're going to displace it about 1 to 1.5 inches to the side prior to injecting. And then you insert the needle, inject the solution, and then release the tissue immediately after the injection. We use this with dark colored medications, such as iron, because these can stain the subcutaneous tissue or skin if they leak out into it. We also use this with very irritating medications, so that they don't get into the subcutaneous or skin tissues. You want to make sure that you use a separate needle to draw up the medication and then discard that and use a new needle for injection. Why do we think that would be? Right, because the needle that's used to draw up the medication is still going to have that medication inside it as well as on the tip and the bevel. So it'll still get into that tissue that we don't want it to get into. So that's why we use a fresh tissue to minimize any staining or irritation. Aspiration will likely be required because this would not be a vaccine or an immunization that we're giving via the Z-track method. And you never want to massage the injection site because that will encourage that fluid to leak out which is exactly what we don't want. Always, always ask the patient about any allergies to medications as well as latex or anything else you might be using in your equipment. If your dosage is 3 mLs or greater, typically you want to divide your dose into 2 syringes and inject into 2 separate spots, but this you want to check with the ordering provider on if what they've ordered is greater than 3 mLs. Always assess the patient's age, size, and muscle condition of the site that you are using while you're deciding which route and site to use. And don't ever give an IM injection at a site where there is any indication of pain or tissue damage, such as bruising, hematoma. Don't ever inject into a muscle where the size and condition does not seem large enough or adequate. For large patients, probably will need a 2 to 3 inch long needle to ensure that the medication is injected into the muscle. And if the patient jerks away or moves or anything like that where it seems like only a partial dose of the vaccine or medication is administered, unfortunately, you have to repeat it. If a patient's getting frequent injections, make sure you rotate the injection site so no scar tissue will build up. And if multiple vaccines are being administered at the same time, use a different muscle site if possible. For infants and younger children, usually it's easier to give into the same limb fairly quickly. So the thigh is the best site to do that because it's a large muscle and you can inject multiple syringes, and poke multiple needles into the same site and the same muscle. Just make sure you always separate them at least by 1 inch. So for older children and adults, if the deltoid muscle is large enough, you can use it for more than 1 injection. Again, make sure that you're separating it by at least 1 inch. And this is probably something you'll practice in the lab. And then if we have anything that's very reactive or has the high potential for side effects or reaction, definitely use different limbs and different muscles if possible. That way we limit the reaction to one site. And always use combination vaccines if possible. Hopefully they're ordered by the provider, but if not, you can always question the order, right? If you know that you have a combination vaccine on hand and the provider orders them all separate, you can definitely bring that to their attention and see if they want to change the order. Because this way, this reduces the number of injections and the number of needle sticks that the patient gets. Always document the location of all of the injection sites in the patient's medical record, right? So if you're giving a Tdap in the right arm and you're giving an influenza in the left arm, make sure you document that specifically in case they have a reaction or a local infection. That way we know for the future that they possibly have an allergy to that specific vaccine or medication. Special considerations need to be made for patients with bleeding disorders or if they're taking anticoagulant therapy, which are drugs to, quote, thin their blood, unquote, because they're more likely to develop hematomas after the injection at the site. So you want to make sure the provider has considered this and has decided that their bleeding risk is low and that the vaccine or medication can be administered with reasonable safety. The patient or family should be instructed about the risk of the hematoma from the injection. Always use the smallest possible size and gauge needle. Now recall that hematomas are just when the blood seeps into the surrounding tissues. And apply firm pressure to the site for at least 2 minutes after injection to hopefully keep that blood from seeping out. but never rub or massage the site because that could have the opposite effect. Always consider if your patient has a latex allergy and determine if what you're administering, the vial or syringe, has any latex, because we don't want to cause a severe anaphylactic reaction unless the benefit of that vaccine or medication clearly outweighs the risk of allergic reaction. If the patient has a local or contact sensitivity to latex, that should probably not be a contraindication to the vaccine. So fainting or syncope may occur during vaccine or any medication administration, especially with adolescents, so preteens and teens and adults. The patient may fall and could potentially become injured. So you want to make sure that you have your patient in a sitting or supine position during injections. It's not that common, and it's not an allergic reaction. Okay, so sometimes patients will say, well, the last time I got my influenza shot, I passed out. Okay, well, that's not a reaction to the influenza shot. That's just a reaction to the experience of getting an injection, right? So if the patient faints, observe them, provide supportive care until they've recovered. Tips for minimizing your patient's pain. Always let the alcohol that you've used to clean the site dry thoroughly. I see this happen all the time out there. People are in a hurry and they just give a quick swipe of the alcohol wipe and then boom, stick that needle in right then. Okay, one, it's going to be uncomfortable because they've just pushed that fresh alcohol into the tissues. It's going to sting, right? But two, the process of drying with the alcohol is what gives it the aseptic property. So if you don't allow the alcohol to dry completely, then the bacteria and germs that you're trying to kill probably isn't killed. So you could just be pushing that right into the patient, which could potentially cause an infection. Always make sure the patient's relaxed and that the muscle in the injection area is relaxed. If it's tensed or contracted, stop, have the patient help them relax. Sometimes I have to put my arm, my hand on the patient's like shoulder if they've got their arm tensed up and kind of give them a little, almost like a little massage to help them relax. A lot of times people have no idea that they're doing this. Making sure that you are quickly penetrating the needle through the skin using a smooth and continuous darting motion will make a huge difference in the pain level for the patient. Okay? If you insert that needle slowly because you're nervous and you don't want to hurt the patient, you're actually hurting them more. Okay? So getting it in a quick, smooth motion, almost like you're throwing a dart, is going to be much more comfortable for the patient. And then you want to inject the medication slowly and steadily. Okay, don't start, stop, start, stop. Just slowly and steadily until it's all gone. And then when you're removing the needle after injecting, don't change direction. Okay, if you've gone straight in at a 90-degree angle, come straight out at the same angle. Because if you change direction, that hurts. Yikes. So possible side effects. Most side effects are a result of the actual drug that's injected and not the procedure itself. So we usually observe the patient for 10 to 15 minutes after any injection for signs of a drug reaction. Remember, we call this a med watch, and it's per site policy how long you're going to do that for. Possible side effects. Minor discomfort and pain at the injection site. That's really common, right? The muscle's going to be sore. You've just, poked a needle in there and disturbed the tissues, so your patient's going to have soreness in the muscle for a couple days. And it's not uncommon to get localized redness, swelling, and of course bleeding at the injection site after you remove the needle. And it's also not uncommon for the patient to have a low-grade fever for a day or two after. Now that's usually from the vaccine doing its job, creating antibodies in the immune system. So adverse reactions and complications are different from side effects. Make sure you know that. So adverse reactions are undesirable reactions that occur. Okay, and then severe reactions and complications are rare. Anaphylaxis being the most severe allergic drug reaction. Excessive pain, burning, or numbness. Okay, so again, they're going to be sore and there's going to be a little bit of pain, but not excessive. And if there's any burning or numbness there, unfortunately that indicates that there's probably some nerve damage, which is not normal. And then a high fever would not be normal. A rash around the injection site would be a sign of an adverse reaction. And then infection at the injection site. Okay, and then if it doesn't stop bleeding after a few minutes, that would be a complication. And if the medication accidentally got injected in the wrong area, that's definitely a complication that needs to be reported immediately. As always, in case of an emergency, call 911. We're going to document the date and time that we've given the injection, the name of the medication, the dose, the route, the site that we used, the manufacturer name, the lot number, the expiration date, the patient's reaction, and your name and title after you've administered the vaccine. And always the VIS date, the publication, as well as the date that it was given to the patient or the parent guardian. So here's a charting example. On 2/14/21 at 9:45 a.m., Hep B was given 0.5 milliliters intramuscularly in the left deltoid. It was made by Merck. Here's the lot number, the expiration, 05/21. No adverse reaction was noted. The mother of the patient was given the VIS. The VIS publication date was May 17th of 2019. That was the last time it was updated. And this is signed by a student, SMA. Okay, so that's the end of intramuscular injections.